Good morning to colleagues who are in the room watching this virtual session. I will present today our research study on private sector engagement in the health sector in Northern Syria. And this project was just to mention, it was funded by MIHAD, a French NGO, which was called before that Awesome France, and in collaboration with Rebuild for Resilience and Midmar in Turkey. And I'm presenting on behalf of the team of researchers. You have the names of all the team members on the first slide here. So moving ahead quickly to a bit on the background or the rationale of this study. As you may all know, we're talking about a very extremely fragile setting in Northern Syria. It's a setting where we have a high number of internally displaced persons, but also limited public resources and increasingly constrained funding for humanitarian assistance. From our previous research, we identified gaps in the provisions of health services due to several factors, despite some collaborative approaches within the humanitarian sector, like integration of primary healthcare services that were explored by colleagues. And also, these challenges were inequitable towards specific, I would say, conditions like non-communicable diseases and mental health services. The whole rationale behind this study is, as colleagues or as other scholars mentioned, about the challenges around the absence of state services leading to the creation of an empty void, and then this empty void being filled by commercial, usually informal providers of curative services, failing to promote equity and efficiency. In other words, moving the health system away from what we expect in terms of goals of any healthcare system. And the whole idea is also to try and investigate sustainable and long-term approaches for the provision of equitable, accessible, and high-quality healthcare services in the northern Syrian context. So our study aimed to explore how, or if I may say, if and how to engage the private sector in long-term sustainable and equitable interventions within the health system in northern Syria. And the specific objectives were first to review the literature around the topic in fragile and conflict-affected settings, but I won't present this for the sake of time today, but also to explore the scale and the performance of the private sector and look at whether we can identify potential areas of interventions and the determinants of private sector engagement in the specific context of Syria. This study was based on an exploratory research design using qualitative and participatory research methods. So we conducted key informative interviews and workshops and participatory workshops with about 35 participants to explore, as I said, the private sector, the scale of the private sector and the role of the private sector in the service delivery and also the overall healthcare system. This work was guided by a couple of research frameworks. So one of them is this health system strengthening framework by Sophie Witter et al. That looks at actually some of the, and try actually to unpack the health system processes goals, and then the processes or the what we expect a health system to do in order to move from a specific set of inputs to a good quality healthcare, good quality services, or to improve health service or health outcomes. And we wanted to actually add to this the role of the private sector, whether in regards to the distribution of human resources, also the specificity of some service delivery aspects and others in terms of governance and other elements of private sector engagement. Also, this work was guided by the market system approach, which aims at looking at identifying incentives and behaviors among market players, including the private sector and the government sector and other sectors, to bring about the desired impact while making the health market more accessible, inclusive, resilient, and financially rewarding. And as you can see, it's a discussion about where the private sector can contribute to, but also what kind of regulations, standards, and norms should be developed in order to ensure that the health of the private sector is engaged while maintaining the functioning and the performance of the private sector. On the main findings of our study, first starting with the scale and role of the private sector in service delivery, and even before that, on the definition of private sector, we had various definitions of private sector by various stakeholders and various participants. So even some colleagues from the NGO sector consider themselves the public sector, given the provision of services for free or without taking any fees from providers. So there was no clear understanding among participants about what we mean by private versus public sector, but we ended up also using the word private sector in the workshops and in this presentation here to indicate specifically the for-profit private entities, while we kept the nomination of the not-for-profit private entities being the NGO sector and the public sector. Is meant to be, we meant by the public sector being the sector that is owned by and controlled by the government itself. So now speaking about the scale of the private sector, our study reported a growing contribution of the private sector to what we call the current NGO-led service model, which replaced the pre-crisis public sector in Northern Syria. The private sector disappeared in the first few years of the crisis, but then slowly re-emerged around the year 2017, 2018. Over the years, the sector migrated with the communities, and now somehow it's located only in wealthy areas of Northern Syria, and it focuses on a selective set of services, such as maternal services, because of, again, the profitable aspect of these services, while the NGO sector and other, and somehow the limitedly available public sector is dealing with the more advanced and less profitable cases in the healthcare system. Now, when we try to explore also the contribution of the private sector to other functions of the health market, whether we're talking about drug manufacturing, private pharmacies, and private labs, we noticed that the private sector or the market itself relies more on imported drugs, which is a new kind of pattern in the Syrian context compared to the pre-crisis situation. And also part of or some of the reasons behind that was the inability to really get drugs from the controlled areas, from other gene-controlled areas, because of the informal charges and then the increased prices of these locally produced drugs. Most of the community pharmacies were private, but the community relies more on the NGO sector to get access to medicines and sometimes to lab services, given the low purchasing power of communities at the current status. Now, moving into the private I would say the human resources situation, and whether they are focused or localized more in the private versus in the public or the NGO sector. Our study suggested that dual practice is a normal pattern, and a lot of health workers, including physicians, usually have multiple contracts with different organizations, different hospitals. Part of it because of the lack of regulations. There was also competition even within the not-for-profit or the NGO sector because of the absence of unified salary scale across organization. Overall, speaking of human resources, there was we noted a shortage of doctors and challenge to create a functional higher education system for medical education and generally for all medical or health workforce production. And the war apparently impacted the mix and distribution of medical specialties in general in Northern Syria. And the key issue is that now the affordability and community preference of the NGO sector is the key determinant of what we see in terms of distribution of human resources across sectors. But we anticipate a future shift because of probably the increase in the purchasing power of communities, and there is a challenge how to maintain maybe the human resources within the NGO sector if it will be available. From a political economy perspective, and to answer what are these features of political economy features affecting private sector engagement, as you may know, we're talking about an extremely fragmented political system. So here, at least you have three regions under the political and military power of different actors, but even within each region, you might see a mosaic of actors competing over the same region. Linking this to the health sector, and in general, some of the de facto authorities in the West are not willing to interfere with the health sector, and this is also a challenge in terms of sometimes they are not even internationally recognizable, but also they are not willing to engage in the private sector, and this sometimes keeps on changing depending on the changing power dynamics and the challenges to maintain, for instance, some of the political decisions at the global level, whether and the NGO sector will be the support across borders, so for instance from Turkey, will be maintained for a long period of time. Now, in terms of health system governance and the link between health system governance and the private sector engagement, we reported also in our study a high level of challenges here because of the availability or the existence of different directorates, for instance, in the West, that are linked to different authorities and different armed groups, and they have, in general, diverse capacities and control, but usually limited resources to operate and to function really as the stewardship, to have the stewardship role. That's why we mentioned that probably they have limited stewardship capacities over the private sector, and they cannot regulate or use hard policy processes to maintain order and to regulate the health sector, especially in relation to the private sector. So there were gaps in the oversight of the private sector in the northern area of Syria, and even challenges were reported in relation to registration and licensing of private facilities being under the mandate of different authorities. So for instance, in the south of northwest Syria, this is under the mandate of an internationally unrecognized government. In the north, it's under the mandate of Turkish authorities, and so on and so forth. And alongside this challenging aspect of oversight, there is kind of absence of strategic vision of the overall health sector, affecting the discussion about private sector engagement and what would be the role of private sector. And apparently there was very limited, or sometimes we can say that there was no attempt to have a dialogue between different sectors, including the private sector, to see what would be the best way to have the engagement of the private sector in filling the gaps in service delivery. So now, just speaking about financing, we just wanted to say that the main source of financing of private services is out-of-pocket expenditure. That's why we have concerns about the affordability and the accessibility of services, especially in underserved communities and for marginalized groups. That's why we ended up having a very preliminary set of recommendations for actors on the ground. Is first to review the policies about registration and licensing of private sector or private facilities, but also to engage the private sector in a dialogue and try to think about small-scale interventions to support the free and low cost access to a specific set of services in collaboration with the NGO sector. So that's it from my end, and thanks so much for listening to this short presentation.